Hi, everyone. I'm Katie Jackson. I'm one of the first-year Pediatric Emergency Medicine Fellows, and I'm going to talk about another adolescent with abdominal pain, and it'll be a case report on stercoral perforation in a pediatric patient. So abdominal pain is one of the most common chief complaints that we see in the emergency department and makes up for about 10% of the visits. Constipation amounts to about half of the diagnosis of abdominal pain in pediatrics, and is usually a benign, self-resolving condition that requires no extensive intervention. Acute abdominal processes involving constipation usually are more along the lines of obstruction and less likely to be leading to perforation as seen in the case that we are going to discuss. So in our case, we had an 11-year-old male, past medical history of obesity and mild constipation that required Miralax daily at home. He presented to our pediatric emergency department with worsening abdominal pain over the last 12 hours. On arrival into our unit, he was in respiratory distress with oropharynx cyanosis, tachypnea, tachycardia, and pallor. A KUB was rapidly obtained that showed substantial free air under the diaphragm bilaterally. He also then quickly received a CT abdomen pelvis that confirmed the intraperitoneal gas and sigmoid wall perforation with an incidental finding of the Meckel's diverticulum. You can see the X-ray and the CT on the right showing the substantial amount of free air, and in the CT you can see the sigmoid perforation along with the free air throughout his abdomen. While in the emergency department, he received fluid resuscitation, broad-spectrum antibiotics, nasogastric decompression, and a stat pediatric surgery consult. After he was seen, he was emergently taken to the OR, where he was found to have fecal peritonitis, and he received a left hemicolectomy, peritoneal abscess drainage, and Meckel's removal. His imaging and pathology report was consistent with a stercoral ulcer due to necrosis, and he had edematous erosive cobblestoning of the sigmoid colon. The pathology seen on the right demonstrates the colonic mucosa with ulceration, and you can see the embedded fecal material on the upper left-hand side. Our patient had a long, torturous course, including multiple washouts in the OR, and he also had multi-organism intra-abdominal abscesses that required peritoneal drains. So stercoral perforation is a rare cause of abdominal perforation in the adult population and almost unheard of in healthy pediatric patients. What happens in a stercoral perforation is there's a large fecaloma that applies constant pressure within the colon, decreasing the transmural perfusion, causing necrosis, and that leads to the perforation. Most common location is the sigmoid colon, which we saw in our patient, but it only accounts for 3% of perforations in the adult population. There's an extremely high risk of morbidity and mortality due to organ failure and sepsis. Most patients that end up with a stercoral perforation have chronic constipation and associated risk factors including opiate use, chronic NSAIDs, or immobilization, which were not present in our young pediatric patient. Thank you very much for listening, and I hope you have a great day.